Hello, and welcome to another edition of Health City Talks. As with the last installment, we're going to be talking about virtual care, but this time we're going to come at it from a slightly different perspective. We have a couple of physicians with us to explore this interesting topic. We've got this great lineup, industry leaders, and they've agreed to spend some time with us, so we're going to talk all about virtual care. My name is Mack Male. I'm the co-founder of Taproot Publishing. We are building the future of local news right here in Edmonton, Alberta. And every Wednesday morning, we publish the Health Innovation Roundup, which is a curated email newsletter that brings together all of the latest headlines and happenings from Edmonton's vibrant health innovation sector. So I'm pretty excited to be once again moderating this discussion, and I'm ready to dive in. So what I'm going to do first here is introduce our panel, and then we'll get right into questions. So first up, we have Dr. Ewan Affleck, who is the past chair of the Virtual Care Task Force of the Canadian Medical Association. He was also named to the Order of Canada for his work on electronic medical records. Great to have you.
Welcome.
Dr. Heidi Fell is a family physician in Calgary with a special interest in the application of IT to doctors' offices. She's also the Alberta Medical Association's Informatics Committee chair. Hi, Heidi.
Hi.
Rohit Joshi is once again joining us. He is the CEO of Brightsquid, Canada's leading compliant communications services provider for the healthcare industry. Welcome.
Thanks, Mac.
And last but not least, we have Reg Joseph, who is the CEO of Edmonton Health City. And Reg brings more than 20 years of experience spanning the biotech and high-tech sectors to this conversation today. Thank you for hosting us, Reg.
Good afternoon, Mac.
Okay, so let's dive in. Heidi, my first question is going to be for you today. What is the opportunity that you see for virtual care from the perspective of doctors?
So I think virtual care adds a really neat additional tool to our toolboxes when we're looking after patients. I think that, not everything needs a visit into the doctor's office where you physically get in your car and drive there, wait in the waiting room. Some things are relatively simple and they can be handled over messaging or they can be handled with a quick phone call. And I think it would be really excellent if we actually had the opportunity to systematically offer that to our patients.
And can you talk a little bit about maybe how you've used virtual care in your own practice, in your own clinic, or your experience with the technology?
Sure. So before the pandemic, I was just using a secure messaging solution so that my patients could communicate with me if they had a simple question about something or they wanted to send me a document that I needed to fill in or something along those lines. Since the pandemic started and we've had more opportunity to use virtual care in Alberta, I've been using some video visits, I've been using an awful lot of phone calls, and I do use the patient portal that's integrated with the EMR that I use in my office as well, so that patients can see some results and I can send documents to them and they can, look at them, send me messages. After the pandemic, they'll be able to book online through that as well. That's a little hard to do when you're worried about COVID symptoms, but so we're using a few different types of virtual care right now.
And I guess maybe it's a little early to say, but do you see these being a continuing part of the practice going forward, or is it really right now geared around getting through the social distancing orders that are in place and the inability of people to get in to see you face to face?
So that's what gave us the leverage to allow this, is that we have no other option right now. We're really trying to see almost all patients virtually and only really seeing ones in person that are considered urgent or that we can't do without seeing them in person. At the AMA, we're really urging and advocating for virtual care to become a constant part of the environment here. But there's some work to do on the policy, governance, funding type of parts before we can make sure that that stays as part of care within Alberta.
Well, we're going to get into lots about policy and stuff, I'm sure. But Rohit, are you seeing similar situation, people adopting this more rapidly at the moment?
Yeah, very much so, Mac. What we're seeing is probably triple the volume of messages going from physicians to the patients and patients to physician that we were prior to the pandemic. And just to kind of add on to what Dr. Fell was talking about, I think this is given a catalyst to something that, I think patients are benefiting from and also health providers are benefiting from. just an increase in capacity and even being able to contact and communicate with patients in ways that they haven't previously had to, and so I think we're at a point where we're starting to see some innovation really hit the ground and see benefit for all sides.
So there's a catalyst at play.
Yeah.
In the last session, I brought up the stat that something like 7 in 10 Canadians have said they'd like the opportunity to take advantage of virtual care. Ewan, I'm interested to hear your perspective on this from the doctor's point of view. Is this something that doctors also want? Is that something that the virtual care task force you were on found?
Yes and no, and certainly I'm familiar with those stats with respect to patients desiring the capacity to communicate with their providers virtually. I think it's a more nuanced answer about physicians, because there are many, and I think Heidi referred to it a minute ago, many sort of policy and logistical and funding and organizational obstacles that stand in the way. It's not simply, hey, I want to do this. Remuneration in many places in Canada is not aligned to support virtual care, where it may be a logical option. So I think many physicians are very interested in this, but there are many obstacles that are not technical. In fact, I would suggest the technical design and ability to deliver upon virtual care is probably one of the easiest things. The issues really rest around licensure policy, licensure payment models, organizational capacity, restructuring your staff, retraining yourself, interoperability, governance, et cetera, et cetera. So I think it can be very challenging for a physician to simply adopt this wholesale, although COVID has certainly ripped the veil off our imperfections as an industry, and demonstrated that we have really not adapted terribly well to the digital age.
So as a patient, maybe I have to install an app and I have to learn how to use the app or something, but there's not a great deal, I suppose, that I need to do in order to start making use of these virtual care technologies. For doctors, though, as I'm hearing from both of you, it sounds like there's a lot that goes into that. So maybe Heidi, you can tell us a little bit about, even just ramping up over the last couple of weeks during the pandemic, as you mentioned. What are some of the things you had to do, or what sort of the barriers you ran into?
So I think the first barrier was that patients didn't know we were still open to talk to them in this manner. They didn't want to come in person, and they didn't know that we were providing these services. So that was the first barrier, is our patients didn't even know that it existed. Some of the second barriers were around technology, just because we're trying to adopt a new technology very, very quickly, and without the chance to check it out beforehand, without being able to fully do our privacy impact assessments that talk about our security and privacy concerns, and the means we've done to protect patients and their privacy about that. Trying different technologies to see which ones work easiest for patients. So, I've used a couple of different virtual video solutions now with patients at this point. Sometimes, depending on the patient, it's still hard to get them to know exactly what to do, even though I have people helping them on the phone. So the easier the technology is, the better, because it will serve more patients more easily. Simple things like the fact that we don't have enough phone lines at the office to handle all the phone calls we're trying to make right now. So we're using our cell phones. Those numbers are blocked. Some patients don't pick up blocked numbers. Some patients have call screening, so you can't get through at all. Just a wide variety of things. And then the fact that I'm trying to use several different technologies at the same time, and they're not all integrated into one nice package. So I'm using, the video solution from vendor A, and the messaging solution from vendor B, and the portal solution from vendor C. And then I switch it up because we've got a different one that seems easier for patients. So, it's just all the challenges of trying to change something. I've been family doc for well over 20 years, and largely we've done it the same way for 20 years, and now I've got to change it in a week.
Right.
So,
And change all aspects of it in a week. Right?
Yeah. So it's been interesting, but not without its challenges, for sure.
I want to come back to the tech, but just before we do that, maybe Ewan, you can talk a little bit about some of the other barriers you mentioned, like remuneration and those sorts of things. Like, what are the other considerations that doctors, physicians need to be considering in adopting virtual care?
Yeah, so virtual care, I mean, in theory, it needs to follow, and not in theory, in practice, it needs to follow the patient in order to work, right? So if the flow of information doesn't follow where the patient, the beneficiary of care, is going, then it's not going to work. And so we have to design virtual care systems that cross interjurisdictional boundaries, that cross, between the Northwest Territories and Alberta, that cross between AHS and AH facilities, that cross to private clinics, and so forth and so on. And because of the way we've historically been structured, many of the technologies that have been developed are developed along the lines of these organizations or governance entities. And so what that has done is interrupted interoperability. And this is what Heidi was just referring to. It's great. She's having to use a variety of different technologies to talk to people, because in different circumstances, in different locations, because as a system, we didn't set clear standards or deliver upon patient-centric interoperability. So then you have on top of that, our policy environment around digital health information is really conflictual. So in some places in Canada, you can do e-prescribing. You can have a digital prescription that is legal. In other jurisdictions, it's not, right? And in some places, that is manifest across, pharmacy acts and health information acts and mental health acts were all written at different times and are not necessarily aligned with supporting the current digital reality. And this is a hard thing to do because things are changing so rapidly. It's not a blameworthy statement, but it is a statement of reality. And then payment models, again, I referred to before, and they vary right across Canada. And there have been the rapid introduction of virtual care payment schedules in most fee-for-service environments. And it's a dog's breakfast. And it's a very hard thing actually to construct. And then licensure, again, has been largely designed around jurisdictions and does not necessarily conform to the flow of the patient, maybe across jurisdictions. So these are all just some of the sort of human architecture issues that impede the use of technology and the provision of virtual care to patients.
So it's not really technical barriers, then it's these other things that influence the technology that we're designing. Yeah. So Rohit, are we still in the design stage of all of this? Like, the technology feels like it's there, but maybe maybe I'm wrong on that. Maybe we are still designing these things.
No, I think the technology is very much there, Mack. I think we've seen, decades of thinking around, how should we communicate better? How do we manage virtual care better? Certainly in the last 5 to 10 years, there's been lots of thinking about that. But again, back to Dr. Affleck's consideration, if we have a business case for how our company might be able to provide benefit for Alberta doctors and Alberta patients, there's no sense of certainty that same business model would work in Saskatchewan or in BC or elsewhere. So it becomes very, very difficult to find even a pan-Canadian solution that makes business sense for entrepreneurs to invest in. And so again, I think it's not the technology, it's the reimbursement. It's how do organizations like ours, find value in the technology that we're providing to providers and patients, but also make it a reasonable business to invest in across Canada, for example.
So Reg, I want to bring you in here. Is this something we can overcome? Do you think there's movement on the policy challenges that we've just heard about?
It's a really good question. I think, to be honest, it remains to be seen. The fact that, we are seeing jurisdictions in Canada act very quickly to piece together systems to enable our physicians to reach patients. You know, it bodes well for us. And the real challenge now is sort of post-pandemic, how are we going to build the pieces that we need to ensure that all the supporting pieces that Dr. Affleck talked about is there to support physicians to be able to offer this service. And do we have all the back-end systems interoperating, working in unison so we can provide that continuity of care as well. So I think that there is a desire to. The challenge that the sector is going to have to overcome is they have to make up for about 20 or 30 years that every other sector has already done. A question that I have for the physicians on the panel, obvious from my perspective as an individual, I find the value proposition of virtual care very interesting as a patient. I don't have to go into a facility. It increases my level of access to my caregivers. Once we've sorted out some of the both technical and policy details, as physicians, do you see virtual care as a win, or what opportunities does it offer you in your practice?
So I'll start, Ewan?
Go for it, Heidi.
Okay. I think, you know, I would continue using virtual care. I wouldn't continue using virtual care exclusively because one of the things that I do find is that I'm actually miss the person-to-person contact with my patients. And that gives us an opportunity to explore things that aren't really good to explore with virtual care and things. So I won't do it exclusively, but I would like to have it as more of an option. You know, it's nice for patients to be able to access their own information, for example. So if a patient gets a CT scan done, I would like to be able to send them a message saying, hey, it's all good, right? And you don't have to wait for, you know, my next available appointment and your next time that you can get out of meetings at work to come see me to find out that everything's okay, right? So, you know, that's a great option. And then there's sometimes that it's just really tough for patients to get in, patients with mobility issues and things like that. If we have a technology that allows me to talk to them in their home, there's also other things that I can learn from learning about their home environments as well. You can kind of see, you know, you can see the background of my house here. You can sort of see what environment people live in. You can learn interesting things about patients that way too. One of the things that I really do want to make sure that virtual care does in Alberta is that it allows me to provide continuous care to my patients. I think it's really important that patients have the opportunity to connect with their own physician. You know, we have really great research in Alberta that shows that the single best thing that you can do for your healthcare, unless you smoke more than 15 cigarettes a day, is to have a family physician and to have a family doc that you know and trust. And so I really want virtual care to enhance that relationship with my patients and allow them better access to me, not to provide, you know, there's always a place for episodic care like walk-in clinics, but I don't want that to replace the connection that the patient has with me. I think that's really important.
Yeah, and so to follow upon Heidi's statements, I agree with what she has said. And I think the value proposition for virtual care is absolute. Virtual care is not a panacea. It can be deployed in a manner that it actually detracts from care, but it needs to be seen as an extension of core practice care that provides another, that extends continuity of care from your core practice. In my context, I've spent almost 30 years working in Northern Canada, and there are huge shortfalls of equity, safe care, because people are in remote and rural locations, that timeliness to care is compromised and so forth. And we've been reliant, the communication technology we rely on principally in the north is the internal combustion engine. We fly people to care, right? And if you look at that and say, well, rather than taking 12 hours and $10,000 to fly someone with some condition, I can actually begin treating them through virtual care technology. It promotes more rapid and safe and equitable access to service. And you may need to fly them out one way or another. So it doesn't replace that, but it provides adjunctive therapy or an adjunctive means of providing care that is profoundly important. And as Heidi says, this can be applied also in urban settings as well, although you can really identify with this in a rural setting and in a remote setting. It's far more evident. So I don't think there is any question about the value of virtual care. It really just needs to be integrated coherently and according to set principles of quality care. And that has been the problem in our industry, is that we really haven't set, for the most part, principles of coherent quality virtual care. We have not defined that. And so as a consequence, it's happening in a disorganized way, often fracturing care, and not integrating service around core primary care services and specialty services. So that's what needs to occur. I think it needs to be here to stay, and then hopefully we can leverage what's happened around COVID to enable this.
So are we at risk of, good being the enemy of done or perfect being the enemy of done? Like, does it really need to be interoperable? Like, we've heard just now, I guess, from all of you that the pandemic has accelerated the adoption of these things. Maybe they're not perfect. They don't interoperate. You have to use multiple systems in your practice, Heidi, for instance, but it allows us to deliver virtual care. It allows us to bring the benefits of those services to patients. Is there a risk that we try to design the perfect system rather than moving forward with something that kind of works, but maybe doesn't meet all the criteria?
I've certainly got an opinion
let's hear
it. I would say that it's absolutely the case that interoperability has to happen. I think that's the primary reason that things have taken so long to actually provide value, that they're now being forced to. And my hat's off to the physicians who've had to, in a whole lot of other pressure that they have right now, start to adopt a whole host of other technologies in order to provide better care. You can imagine the layers of stress that are happening and that we're hearing about. And so I think that for true benefit to accrue to the providers as well as the patient, unless there's that continuity of the record, unless there's that interoperation from one modality to another that ends up in a contiguous record for that patient, we haven't done our job. I mean, I feel like I should modify my earlier answer, which was, yeah, we're done technology. And from that perspective, we're not. We haven't even started in terms of developing a very light lift, I would say, to interoperate between systems. And I think that it's going to take some leadership from physicians groups, from government, in order to make that reality.
If I may say, Rohit, I don't think although the lack of interoperability is manifest as a technical shortfall, it does not arise from that place. It really arises from deeply fractured, I like to say in Canada, we are constitutionally designed to have e-health fail, because the Canada Health Act states that health oversight is a provincial and territorial mandated activity. Hence, each jurisdiction designs its own systems, and we have basically instituted very successfully a cross-sectoral lack of interoperability, and that is what, and it goes on and on and on. So, although it becomes a technical problem, it does not have a technical origin. There's a deep governance problem that we need to address in Canada around e-health that is impacting us all.
And you think that'll take leadership from government, from elected officials, from doctors, all of the above?
It's very interesting, right now, I mean, we just have to call it out. We have to say what it is. I mean, patients, the last time I checked, they don't magically stop being ill at the edge of some boundary between one province and another, or a territory. Illness goes on. I mean, it's bizarre, and our industry is an information industry. If there is no information, there is no care. When Heidi sees a patient or I see a patient, we adjudicate all care based on the information we can accrue either directly from the patient or in their antecedent record or in the literature. And so if you eliminate that, you have no care. So, and when that information is attenuated, right, the likelihood of you making an error is worse. But we've then manufactured this thing where magically information stops at certain borders just because of governance. So it has nothing to do with healthcare, nothing to do with the patient, and we have to call it out and recognize it and say, hey, we better figure this out and get along.
Those borders aren't always geographic either. Those borders can be a specialist office versus a family doctor's office versus a hospital as well. So those borders that prevent information from flowing can be technical, but they're often cultural, they can be geographic, and you know, political. They're all over the place. Political, yes. And so I think that, yes, leadership's going to be needed from all aspects to do this, and it's going to have to be leadership in partnership. It can't be leadership in silos either. It has to be government working with physicians, working with the technology providers, working with other types of healthcare providers, because physicians are increasingly working in teams, working with patient groups, especially in order to make this work for the patients at the end of the day. Right now, it doesn't really work for anybody. So, you know, that's not ideal. With interoperability, I think just from a practical perspective, a modern medical practice is so pressed for time. So in order, especially, and it doesn't really matter the payment model, fee for service certainly, but doctors in the United States that are on salary describe the exact same time pressure associated with it. Just practically, the requirement that I need to have all the information in my one legal record of care for medical legal reasons and for the reasons Ewan talks about needing to have that information to take care of the patient means that nothing will really fly unless it's easy for both the patient and the doctor. And until it's easy for the doctor, i.e. integrated into the system that they're using all the time, and easy for the patient, it's really not going to get the legs that it should and that it needs to really succeed.
So it sounds like it's hard right now. How are you dealing with that challenge at the moment?
Right now is a pandemic. So right now is about survival.
Okay.
Both from a patient perspective and a physician perspective. Frankly, you know, medical clinics are struggling financially at the moment. They're struggling to adapt to all this change at once. They're struggling to keep themselves safe. They're struggling to keep their patients safe. So, you know, right now is really about survival. It's not about optimization. It's about getting the job done to the best of your ability today. And so that's not the type of environment that will be able to be sustainable in the long term.
No, but perhaps there are lessons to come from
for sure.
this current experience that could be applied. Yeah.
Yeah, for sure. We will learn lots, and you know, patients will learn that they like this method of care for some things. It doesn't work when I actually need to touch you in order to feel your abdomen and tell if there's a problem. You know, it doesn't work for things like that, but you know, patients will learn that this is a really great model of care for some things. You know, docs will learn, okay, it is doable with some types of support. And hopefully government will learn as well that this has value to both patients, doctors, and their care teams too.
So talking about interoperability, about having that data flow and having that information available, you know, something that then comes to mind when we're talking about information moving around is privacy and security. And we've heard a lot about that in the news lately, mainly in relation to, you know, contact tracing apps and the privacy of your location and things like that. Or perhaps Zoom bombing is the other reason it's come up recently. What's the state of play on virtual care currently, Rohit, around privacy and security?
Yeah, a great question. You know, I think what happened at the beginning of the pandemic was there was a rush to really use whatever tools were available from a physician standpoint, and we found a lot of endorsement of products that weren't interoperable, but also maybe weren't as safe as the industry would have liked. We found that lasted about 3 weeks when cooler heads prevailed, or when the opportunity came to re-examine things, I think we saw that there was quite a few things that were happening by patients, concern around privacy, concern around the security of the tools that were being used. And I think there was a subsequent kind of clamp down back to where there was a scrutiny that occurred at governmental levels around the products that were going to be used for transmitting health data. And so I think that quite naturally, when the pandemic hit, everybody used whatever tools were available. But since then, I've found, with the bad press and with the bad situations that occurred, people have come back to some sense of privacy, security, regulated tools, and so on.
How are physicians thinking about privacy and security? Maybe Heidi, we start with you.
So that's always important to us. Confidentiality is one of the key things that we build a relationship with patients on. So it's important that private stuff be kept private. However, it's also important that we have the ability to provide you with appropriate care, which means I may need to give information to a specialist. I may need to get information from a hospital. You may need to send me something as a patient, like a picture of, a rash or something like that. And so there's a balance between allowing the appropriate flow of information and still guarding that very core principle that we have as doctors, that your information as a patient is important and sacred to us, really. It's important for us to do our job, and it's important that we keep it safe so that you feel that you can trust that you can tell me anything. Virtual care adds some interesting layers to that in terms of, so it's flying around the electronic universe now. Where is that information flying? Can anybody intercept it? What's happening with that? And, Zoom bombing is a good example that's not a good, safe practice.
Right.
And, other things like being in the room where can you be overheard, for example, which in the pandemic is a challenge, I have to say, because there's, like in my clinic, for example, there's no cell service in the back rooms because it's a concrete building. So that produces limitations on where we can physically take calls, but, ensuring patients still have privacy on the other end, knowing who's on the other end of the phone, because sometimes you're on speakerphone and you don't know it. And sometimes that's great because you can have more than one person in the conversation. So adding the virtual care to the in-person care just adds a whole bunch of layers of things that can potentially go wrong with security. And so it means we need to think a lot more carefully about it. And, in a pandemic, we do what we need to look after patients. But that doesn't mean we don't think about privacy and security too.
Right. Some of the things you talked about there made it sound a little bit like, the approach to serving a patient, treating a patient changes slightly because of the tools that you're using, because of the technologies that are available. I mean, Ewan, maybe you can speak to that a little bit. Is that what we anticipate needs to happen? Doctors need to change the way they do their jobs to some extent to use these technologies, or are we thinking, more that we need to make sure the technologies fit the way doctors already do things?
Yeah, exactly. What the chicken and egg there, I think that's what I was going to say. I think you have to ask a very basic question every time you're addressing a clinical situation. So in a given case, X, Y, Z is happening. And you have to ask the question, what information do I need in order to ensure that this person has a quality outcome? So, and can I get that information through virtual means, or do I actually need to see them? And so that question needs to be asked, because our core obligation is to provide quality care. So you're not going to adapt to the technology in order to provide care. Hopefully the technology can be used to promote quality care. And so, yes, the second I would suggest of your two options is the correct one.
Is the right way to go. Okay, makes sense.
I have a question.
Go ahead, Reg.
So we've been really focused on the physician-patient relationship in this conversation because we have two physicians here. But I was wondering if you might be able to comment a little bit about the opportunity to extend to other clinicians and other allied health professionals. Is there an opportunity for virtual care there? And are there any concerns broadening the scope, if you will, for virtual care?
So one example that we're doing right now is we have a service in our office called Shared Mental Health Care, where we, I'm in the room, patient's in the room, and the therapist is in the room, or the psychiatrist is in the room, depending on the circumstances. And so during the pandemic, that has switched to a virtual service. So we're actually using teleconferencing apps to provide that same service. And that's an example of something that did translate fairly easily to virtual care, because it's a talk-based service. There's lots of physios around that are doing virtual physiotherapy as well over video conferencing and telehealth and things like that. And I imagine that provides them some challenges because it tends to be a more hands-on discipline, but there are still some things that they're able to do over virtual care, like observing how a patient does exercises, for example. There's no reason why pharmacists can't follow up with patients over messaging, for example. And then in a family doc's office, we have lots of team as well. So if you're part of a PCN, you may have a psychologist as part of your team. You might have we have a pharmacist as part of your team. You might have a health management nurse as part of your team. You might have a nurse practitioner as part of your team. And so, they often use virtual care methods, including phone, to reach out to patients. And then they can also use those methods to communicate with me if needed too. So that there's lots of different opportunities for virtual care to be used in other professions, and also in a team-based care environment where lots of professions are working together to care for a patient.
Yeah, virtual care is not a bilateral activity. It's a team-based activity, as Heidi has just said. And really, what it is about networking, right? So if you have people connected across the circle of care, you can, I may need to ask an orthopedic surgeon what their opinion is on an X-ray or something of a leg, and so you ask them. So this is all going on, and you want to ensure that you have a network effect, as it were, and that's why it brings us back to the importance of interoperability. And the patient has to be central to that network of people in their circle of care to be effective. So it is certainly not about physicians. There happen to be two hanging out here, but right. It might just as well be other healthcare providers that are here.
I have one more question for Rohit, if I may. We've talked a lot about government policy. We've talked about physicians and the effect on their practices and even patients. What is the role for industry here, Rohit, and what should companies be thinking about as we start really moving down the track of digital health in general?
Yeah, great question. I think it's probably captured in a couple of different elements. For starters, and Dr. Fell alluded to this earlier, there's a very high standard in terms of security and privacy, and that really is the foundational element that I think digital companies, innovators need to start with. I know that even in the last few weeks, we've seen technologies show up that we're probably not ready for market. In taking advantage, I would say, of a crisis to come to market with products that weren't ready. So I'd say that's a foundational element. But then as we head into that world of providing care, the other large thing that comes up is what's the plan for data governance? If we're regulated as industry, we're still regulated by the laws around patient privacy. But there's a much bigger discussion to be had around who owns that data. And unfortunately, we, again, have to be careful that there aren't companies that are there monetizing that data without the appropriate permissions and without the appropriate benefits for the stakeholders, because that's a very, very short-lived approach. And so I think, as innovative as healthcare wants to be, or as I see other innovators want to be, there are layers here of guidance and governance that need to play for us to protect the entire ecosystem of users, the providers, the patients, and everybody in between, including the technology companies like ours.
And the
So
patient needs a say in that governance.
Absolutely, yeah.
Yeah, that was going to be my next question. I was going to say we're rapidly coming to the end of our time, but I wanted to make sure to ask you all, what is the role for patients here? Like, what should patients do, or what can patients do to make sure that some of the barriers and the challenges that you've all identified can be overcome? Maybe we can start with you, Heidi.
So I think it's really incumbent on us as people with a voice in the healthcare system to ensure that patients get a voice in the healthcare system. You know, my own experiences as a patient or as a mom taking my children through the healthcare system is that patients don't have enough voice within the healthcare system. And so I think we really need to advocate that they have that voice, and that voice extends to what happens with their data. You know, yes, doctors generally and other healthcare providers, but thinking of myself, I take care of that data for patients. But, you know, they need, you know, the culture is shifting, that patients have more access to that data, they have easier access to that data, and then they need to start having some real influence on what happens to that data as we start looking at aggregating that data into larger groups. So there is a ton of things that we can learn from aggregated patient data. You know, I was talking to a startup company, for example, that was able to predict the spread of the coronavirus before it actually happened based on using aggregated data. It wasn't anybody's personal data. It was aggregated and kept private and all that kind of stuff. But there is a ton of stuff that we can learn about that. But unless we have patients involved in telling us what's okay and what's not okay to do with that type of data, I don't think we're going to get it right.
Okay, so we need to make sure patients have a voice to advocate for some of that. Ewan, what do you think?
Yeah, I mean, I think I would, first of all, I'll turn off my phone. Sorry about that. I think I would, yeah, I agree with Heidi. It's sort of a dirty secret in healthcare that the owner of the information has largely been excluded from any power over the destiny of that information. So patients own that information from the Supreme Court of Canada decision in 1992, and yet we don't act that way. And the question is why we don't act that way. And so that the empowerment of patients to define the use of their information is their personal information is an absolute necessity. The second thing is what we do with aggregate data, and that's a more nuanced thing, and we really have to define what the greater good is here, because these are topics that need significant discourse in the industry, and I think, again, similar to what we were saying about the political and governance obstacles to interoperability, this is another significant area that requires leadership in Canada, and we probably need a charter of patient rights and information rights and responsibilities that is broadly accepted across the country. Something of that sort would be very valuable, and that is endorsed by all parties and upheld.
Right. What about for industry, Rohit? I mean, I obviously want users to be users, but what else? What other role do they play?
Yeah, it's a great question, and I know that Reg and I have spent many hours talking about this. You know, as a private company, we probably have now about 4 million bits of patient data, and I myself and my board and all of us are very, very patient focused, and so and from that perspective, we want to make sure that we're properly governed as well. And so I think for companies that are looking to profit off of that data, they've got a very, very hard future, because I think patients won't accept it, and neither will the political regime, nor should they. So for companies like ours that are deeply committed to the patient world, we want to make sure that there is a governance that protects not just the patient, but also companies like ours, because we believe that that's the way it should be. And I think that most companies that I'm connected to, for sure, feel the same way. Industry is ready to be to engage in that discussion, you know, in the patient-first strategy of having ownership and benefit to the patient. We're ready for that discussion and welcome it.
Okay, well, we're right about at the end of the time here, so I'm not going to make you make any predictions for the future, but I would like to give each of you the opportunity to end on maybe what you hope is on the horizon for virtual care from your perspective. What do you anticipate we're going to see, or what would you like to see to help move this forward and make some of the benefits that you've identified a reality for people? And I'll vamp here a little bit longer, but maybe we'll jump in with Rohit. Do you want to start?
Yeah, happy to start. So I've been you know, as a patient, I'll speak from that perspective. I've been the benefactor of virtual care. And I have to tell you that it was absolutely the way I would choose to be cared for in the future for a series of things that I would like. Not exclusively, to Dr. Fell's point, there are times that I need to see my doctor, and there's times that I want to confide and want to be close to that physician in terms of my own health. But for many, many routine opportunities and operations, I would just as soon have good communication, all's good. And I hope that for other patients. And I'll end there, you know, speaking as a patient, I'm hoping it doesn't change.
Right. Ewan?
So I'm hoping that we can leverage what has happened with the pandemic to recognize that we can be more nimble in this industry than we standardly are, because we have not had a great track record of sustaining and spreading innovation, certainly around information technology. We have good instances, but really as a nation, we have fallen behind in virtual care relative to many places in the world. So, but we have had to be nimble, and it's a bit awkward now because, you know, we've just sort of bolted this together in the face of the pandemic. But we're demonstrating, I believe, that there is absolute value in virtualization, and I think we can learn from that. I am hopeful also that we can reimagine healthcare a bit through more pan-Canadian lens, because I don't think virtualization lends itself effectively to a fractured governance environment. So we have to begin getting along with respect to the principles of design around virtualization that will uphold patient-centric and continuous care. So that's my hope.
Reality is a different thing, but thank you for sharing that. Heidi, how about you?
I think at the end of the day, I just want this to be a sustainable option that I can use to provide better, more accessible care for my patients. Really, you know, it's been coming in baby steps over the last few years, and you know, now we've opened the floodgates, and you know, give us a chance to find out what the optimal balance is and how it actually optimally works in a medical practice and for patients.
Yeah, move past those baby steps a little bit. Reg, I'm going to give you the opportunity to have the last word. Oh, you're muted there, Reg.
Thanks, Mac. From my perspective, I think the real opportunity here, which gets me excited, is what we've seen in other sectors. When we look at the disruption in the media sector, in transportation, and so forth, we find a closer connection between the provider and the user. And I think that ability now, if we truly go digital and embrace that technology, that ability for us to have that better connectivity, a patient with their physician, moving actually from episodic care in a way, sometimes we only see our physician once a year, or for many people, sometimes it's less than that, to now maybe visit them personally once a year, but have ongoing conversations with them on a regular basis. And I think that digital platform will enable us to do that. I think also if we use this right, it increases access and also enhances the patient's voice. And so I think these are all things that could be really enabled by completely going digital. We know that there's a number of challenges there, but I think we could really see a paradigm shift in health if we truly embrace the digital environment.
So some challenges to make virtual care a reality for all of us, but some huge opportunities and potential benefits to come from that. I think that's a great point to end it on. I want to thank everyone who participated in this conversation. Rohit Joshi, Dr. Ewan Affleck, and Dr. Heidi Fell, thank you so much for sharing your time and perspectives and experience with us. This has been Health City Talks, Virtual Care. You can find more editions and everything else that Health City is up to at edmontonhealthcity.ca. And you can learn more about what we're doing to pay attention to all of the interesting things happening in health innovation in Edmonton at taprootedmonton.ca. Thanks, everyone.
Thank you.
Thanks, everyone.
Thank you.